good afternoon. I'm Sarah Mulkey. I'm the director of the Fetal Neonatal Neurology Fellowship program at Children's National, and I'm really pleased that you could join us today for our webinar on fetal neurology. And I wanted to do this because it's really a new and very exciting developing field within child neurology, and not everyone has had exposure to this field, what we see, how we do it. And so the purpose is really to give you an introduction to the field, especially for people who may be interested in pursuing subspecialty training in fetal neurology. So the objectives of the webinar today are to describe the growing field of fetal neurology, discuss the multidisciplinary approach that we take for these consultations, provide an overview of the clinical practice, discuss fetal neurology training opportunities, present research opportunities in this field, and then address specific questions about the Fetal Neurology Fellowship at Children's National. And some of you have given us some questions ahead of time, and I hope I address those. If not, you can post questions during the webinar or email them to us afterwards. So what is fetal neurology? Fetal neurology is an emerging field of child neurology. It evaluates neurologic abnormalities at the earliest time point. So even prior to birth, we can make neurologic diagnoses using special techniques. We can evaluate for differences in brain development, malformations of the central nervous system, neurogenetic syndromes, and congenital infectious encephalopathies, among other things. It requires knowledge of normal fetal brain development and an understanding of neurologic outcome. And it is incredibly multidisciplinary. So Children's National has a Fetal Medicine Institute, and I just want to give you an overview of that. So it is a very unique program because it is housed within a children's hospital. We do not have labor and delivery services here, and so the only pregnant women we see in our hospital that are coming to visit us as patients are coming to our Fetal Medicine Institute for evaluation. We provide comprehensive fetal imaging with ultrasound and MRI, and then provide the opportunity for multidisciplinary consultations with pediatric specialists. The goal is to provide the most accurate diagnosis of the fetal condition and provide the prognosis for the condition to the expectant parents. This knowledge can then be used to improve fetal neonatal transition, enable for planning of postnatal care. Within our Fetal Medicine Institute, we see about 1,000 cases per year. About 300 of these are fetal cardiology visits. And when we look at the other types of visits, we can see that neurology is about 300 visits per year. Some of these patients have multiple types of consultations that they receive, depending upon what organ systems or problems are involved with the fetus. When we look specifically at the neurologic conditions that we see, you can see that ventriculomegaly is by far and away the largest number of types of cases that we see, with about 110 cases per year. And then many other different kinds of neurologic conditions. So microcephaly, and of course that goes along with Zika virus consultations, but many different types of malformations of the fetal brain warrant a fetal neurology consultation. So agenesis of the corpus callosum, holoprosencephaly, concerns for Dandy-Walker malformation, and you could just see the long list there. The main diagnosis seen in fetal neurology, so as we said before, ventriculomegaly is the #1. Next, abnormal head circumference, which has certainly been a hot topic with Zika and concern for small head and microcephaly. Malformations in cortical development, many different kinds we can see, including holoprosencephaly or anything along that spectrum, malformations in cortical folding. Midline brain anomalies, such as agenesis of the corpus callosum and absent septum pellucidum. Posterior fossa abnormalities, including brainstem and cerebellar abnormalities. Dandy-Walker malformation and variants go along under that category. Fetuses can have acquired lesions to the brain that could be infectious, vascular, hemorrhagic, or ischemic, and these are all things we can see and evaluate. And then prenatal genetic syndromes, some of those have with them a brain difference that we would diagnose. So one of the first tools we use is a fetal ultrasound. And this, of course, is what typically prompts the maternal fetal medicine specialist to identify an abnormality in the fetus that warrants a referral to a center with a fetal neurologist. And so by ultrasound, we can look at the brain measurements or the head measurements, both with biparietal diameter and head circumference. And I've shown you those images there. But fetal ultrasound is really helpful for assessing the fetal growth, the measurements of the body. So with ultrasound, we can measure the bone length, which is not something easily done by MRI. And of course, the head circumference and biparietal diameter. We can evaluate the other body systems with ultrasound and look for other types of malformation, such as clubfoot abnormality. We can look at the ventricular size. So with ultrasound, we can see the fluid spaces pretty well, and so we can describe the ventricles. We can look for fetal intracranial hemorrhage or differences in the choroid plexus. The spine can be imaged pretty well by ultrasound to look for myelomeningocele. Cerebral cysts often show up better by ultrasound than MRI, so it is useful for that reason as well. And then the amniotic fluid index can be done with ultrasound only and not MRI. And that is important as a neurologist because a large amniotic fluid index may give you an indication that the fetus is not swallowing well, and that could be due to neurologic dysfunction. So ultrasound is important in your evaluation. And then, of course, fetal MRI has really revolutionized the field and enables us to make these special types of neurologic diagnosis in the fetus that really would be hard to accomplish with ultrasound alone. And so with MRI, we are able to image the brain in the axial, sagittal, and coronal planes. And it doesn't really matter exactly where the fetal position is, since we are able to get at the fetal head and image in the ways that we need to. We can also evaluate how the brain is maturing, since we can see the detail of the brain so well and see if the folds are happening as they should for that gestational age. Fetal MRI mostly involves only two weighted sequences, since they are faster sequences and they are not as susceptible to fetal motion artifact as are T1 susceptibility and diffusion weighted sequences. We sometimes do these other sequences in the fetal MRI, especially if we are concerned about a fetal stroke or intracranial hemorrhage. Also, T1 is useful for looking at the bowel. But fetal MRI requires the expertise of really a dedicated fetal MRI center that has MRI technologists that are used to imaging the fetus. It is very complicated, especially when you're trying to image a very small thing that is moving on you, and radiologists that are also very experienced at this. Our women are often in the scanner for a long time, and typically over 1,000 images are taken for a single clinical case. The advantages of fetal MRI to the fetal neurologist are many. It really gives us the detail of the brain structure that we cannot appreciate by ultrasound. We can see the lamination pattern. We can see how the brain is folding. We can look at the ventricles both in their shape and how they are lined. It also enables us to get a really nice sagittal image of the brain, so we can see the entire length of the corpus callosum. We can see the cerebellar vermis and the brainstem very well. On ultrasound, really, it's hard. Those are hard types of structures to see. Usually, you can see the vermis, but to really see the brainstem and corpus callosum in its full length, you need the MRI sagittal image. We can also measure specific brain structures, and we have normative data that we can compare them to. Not only are we looking at the head circumference and BPD, but we can see is the corpus callosum the right length for 24 weeks, which gives us a lot more information. And then we also can do clinical brain volumetrics if we are able to get 2 millimeter thickness slices on our MRI. And shown in this graph here is a fetal case that we evaluated where we were plotting the brain volume by gestational age. And all of this together enables us to really get a good understanding of the fetal neurologic condition, a diagnosis, and then offer our prognosis. So here are some of the measurements that we get, just to show you kind of how we do this. So in this upper image here, we have, my arrow will go up here, we have the frontal occipital diameter that we can measure. We have biparietal diameter. We can measure the transverse cerebellar diameter. Here is the height of the cerebellar vermis. And this mark up here is the length of our corpus callosum. So many measurements we can do. So to give you a flavor of the things that we see, so the thing we see the most is ventriculomegaly, and there is a huge range of ventriculomegaly. And so showing you this range, here in the image on the left, we have a fetal case at 28 weeks with mild unilateral ventriculomegaly. This can certainly be a normal finding, but it can also be due to part of a genetic syndrome. It could be due to a congenital infection. It may be a progressive ventriculomegaly that if we were to follow this later, we would see that it is increased. So this is important when you see this to look at the rest of the fetus and try and understand whether this is an isolated finding or not. This image on the right is severe fetal ventriculomegaly at 21 weeks due to aqueductal stenosis. The posterior fossa is very well imaged by fetal MRI, and something that by prenatal ultrasound can be really hard to define the abnormalities of the posterior fossa structure. So fetal MRI can often really offer a much more accurate diagnosis. So this was a fetus referred to us at 17 weeks and 4 days due to suspected posterior fossa abnormalities. And you can see in this axial image that the vermis is very hypoplastic and there is a large fluid space posterior to the cerebellum. In the sagittal image, we can see kind of the hallmark findings of Dandy-Walker malformation with elevation of the tegmental vermian angle and vermian hypoplasia in this large fourth ventricular cyst. And so with fetal MRI and a fetal neurologist, you can really make a very accurate diagnosis of this condition prior to birth. Myelomeningocele and Chiari II malformations are well seen on fetal MRI. This was a case referred to us at 21 weeks with bilateral ventriculomegaly and a mom with elevated maternal serum alpha-fetal protein. So first, looking at the brain, on this axial image, we can see that there is mild ventriculomegaly, since the ventricles are about 13 millimeters. There's also really the absence of subarachnoid space around the brain. Okay. When we look then at a sagittal image of the brain, we can see a Chiari II malformation. Yeah. And then when we look lower at the spine, we see the finding of a myelomeningocele. Fetal MRI is very important then for these types of cases, and there's consideration for fetal therapies and surgery for these to prevent or reduce the likelihood of developing hydrocephalus.
I appreciate it. Okay, thank you.
Midline brain anomalies is another thing we see a lot of. Here, this is a consultation at 21 weeks that were sent for absent septum pellucidum and concern for Dandy-Walker variant. We found a genesis of the corpus callosum, and so you can see the absence of the corpus callosum on these coronal and axial images. There's the ventricles are upper limits of normal. And on the sagittal image, we did not see a Dandy-Walker malformation, but we do see a little increase in the tegmental vermian angle, more consistent with what we feel is probably a Blake's pouch cyst. But because of this, the vermis looks a little different, and so there may be a difference in the cerebellar vermis as well. So I've given you a flavor of fetal neurology and what we see, and so now to kind of discuss how we practice fetal neurology. And so as you can see, our diagnosis is based on fetal imaging and then maternal testing that is done in addition to that. And so this requires a multidisciplinary team. We have fetal radiologists and neuroradiologists that are excellent at interpreting these images, and the neurologist needs to work very closely with them to review the images, discuss the findings, and then proceed with how the consultation will go. We also need clinical genetics and genetic counselors to help us interpret the maternal testing and provide recommendations for further testing. And then you need other people on this team too. So you need neonatologists that can address how the care will need to be for the baby after birth and counsel the family with what to expect. We need neurosurgeons, and we need many other available subspecialties to really do this, because many of these babies that we do consults on have more than one system involved. And then it requires great communication with the referral physician, so the maternal fetal medicine physician or OB, because they're the primary physician that is going to be managing this mother's pregnancy until that baby arrives to see you in your hospital. And then the findings that we see, it's very important that we then disseminate them to the birthing hospital so that when that mother delivers, the neonatologist or pediatricians that are going to be taking care of that baby know about your concerns and know if there's anything they need to do right away for that baby. And then I think the part we always need to keep in mind is that the brain is rapidly growing and developing as we're seeing it. So we may first meet this fetus at 22 weeks, but we don't have a crystal ball, and we don't know exactly what's going to happen between that 22-week time and the time that that brain becomes 40 weeks. So you can see the huge amount of growth and complexity that is occurring. And so even when we see a normal fetal brain image, we don't have that crystal ball, and we can't know for sure that development is going to continue normally. So we always have to be cautious in how our prognosis is. So to show you our clinic where we do this, so this is the entryway to our clinic. Within the clinic, we have ultrasound rooms. MRI is done in our main MRI imaging suite, which is downstairs from the clinic. The radiologist sits up in the clinic and has a special room there to view the images so that we can consult face-to-face with the radiologist and look at the images together. The typical patient schedule, it's a long day, but we like to do it all together in one day so that the mother is not waiting for the information, and that way if we needed to get additional imaging, we're all there together that one day. So the mother usually comes in early, gets a fetal MRI, which is followed then by ultrasound. The team reviews together with the radiologist and the neuroradiologist and also the genetic counselor. We all review together the imaging, the previous testing that the mother has had, and make a plan for what our diagnosis is and what needs to be done, and then how we're going to counsel about prognosis. After the neurologist would see the patient or a different subspecialist, then other consultations may occur if there are multiple systems involved for that case. And then immediately following the consultation, we call the referring provider to let them know our findings and results, and they really appreciate that quick follow-up. So the structure of our consultation, so we don't have our patient as the fetus, but our patient in this case really is the mother. So we can't do a physical exam, but we do our exam by looking at the imaging. So we start with getting a patient and family history, just like you would in any other case, discussing her pregnancy and health during the pregnancy, any family history of neurologic conditions, developmental delays, epilepsy. We evaluate the previous prenatal genetic testing she has had, if there's been any testing for congenital infections, what those results are. We look at their prior fetal imaging findings and the measurements of those findings. We assess their current understanding of the condition. And then our main job at that point then is to teach about the brain and teach about the condition. And we do this using diagrams that show the ventricles, or may show the spine if we're worried about a myelomeningocele. We have a brain model that we can show the folding and where the cerebellum is, and the brainstem and the corpus callosum. So we try and educate about these complex brain parts that we talk about. These are the consult rooms that we use. So we have a large computer monitor where you can show the mother what the images look like. We have our brain model. We have the other figures that we use. There's seating then for the patient. Sometimes they have family members, or sometimes we have an interpreter with us as well. We have our genetic counselor or a nurse practitioner, and then we have multiple learners since we're a teaching hospital. So we have our fellow, and sometimes we'll have other residents with us as well. So during a consultation, the typical results that we have to report, we love it when we get to say things are normal or it's a normal variant, and we do get to do this, which is wonderful and certainly makes for a happy consultation and happy tears of moms. Other times we confirm the referral diagnosis, but we can see it in greater detail. We can rule out other findings. And then sometimes we do find that there are new findings that weren't described on the outside sonogram, or the findings that we see are worse than were expected. So our goal is always to make the most accurate diagnosis, but we do have to keep in mind limitations of fetal imaging. So as I showed you, the brain is rapidly evolving during the fetal period, and so some conditions may not be fully recognized until later in gestation, especially things like polymicrogyria or lissencephaly. Until the brain has had time to fold properly, we don't really ever know that that's truly going to happen normally. And so sometimes things change. We always have to keep that in mind. We then really work hard to describe the outcome of the condition. And so as pediatricians and child neurologists and neonatologists, whoever would, we have an experience in seeing what these conditions look like on the outside, and it's our job to explain that to the families. So will this baby be able to transition at birth? Are they going to need to be intubated? Those are very important questions. Do they need to go to the NICU? What's the early developmental impact of that? What kind of doctors are they going to need to see? Are they going to need therapies? And what is the childhood outcome? This is what we need to explain to these families. And sometimes there's a range of possible outcomes. So for like agenesis of the corpus callosum, we need to describe that full outcome, which may be normal and may be very abnormal. And then it's very important that we understand pregnancy options based on the gestational age and where the family is at with how they feel about what you're telling them. And then follow-up planning. So for the fetal period, the patient continues to be followed by their MFM-OB. We may recommend further testing to be done, like more specific genetic testing or testing for congenital infections or fetal neonatal alloimmune thrombocytopenia. We then, depending upon what we see, we may consider a third trimester follow-up evaluation in our clinic. Sometimes this is to see the neonatologist if we're concerned they're going to need the NICU. We want them to meet the neonatologist ahead of time or the neurosurgeon. This may or may not be with imaging. And then sometimes we have a case we've seen earlier, and the MFM will contact us if there's a change. So the ventricles got much bigger, then we may bring the mother back for another fetal follow-up. Otherwise, we make a postnatal plan for every baby. This could be NICU or outpatient. We give the recommendation to the birth hospital. The mother also gets a copy of the recommendations. There may be postnatal imaging recommended, which would be brain MRI or cranial ultrasound. They can follow in our neurology clinic, which we have through our Fetal Medicine Institute. They could be seen in genetics or other subspecialty follow-up appointments. And sometimes our fetal case is, of course, normal, and we just recommend regular pediatrician follow-up after birth. So training in fetal neurology really requires access to a high volume and rich variety of fetal neonatal neurology cases. There are a lot of different types of conditions that we can diagnose, and unless you've seen a lot of them and have the opportunity for that, it would be hard to really understand the long-term impact of all these findings. The program needs to have mentors with expertise in fetal neonatal neurology, and it's best when it's integrated into a neonatal neurocritical care program so that these high-risk babies or babies with complex neurologic conditions diagnosed prior to birth have access then to a neonatal neurocritical care program to take care of them after birth, and it allows the trainee to then see the fetal side and the postnatal side of care for babies with those conditions. You need exposure to a fetal neuroradiology program with interpretation, and so time spent with fetal neuroradiologist is very important. Having longitudinal exposure from the pre to postnatal period, so following through that whole time period is very important. Multidisciplinary case discussions, which include maternal fetal medicine specialist, geneticist, radiologist, neonatologist, neurologist, and palliative care. And a program really takes 2 years, including research time, to really get this proper training. And there was a paper published with Smyser et al. In 2016 on kind of what a fetal neonatal neurology program should look like. And Mark Schur had also written on that as well. So Children's National Fetal, Transitional, and Neonatal Neurology Fellowship is really a very unique training opportunity with wonderful mentorship. There are, I think, very few programs like this, certainly in the country, that offer this type of experience. We see greater than 300 fetal neurology consultations per year, and the consultations are done by experienced fetal neurologists. We have multidisciplinary training in a top 5 children's hospital. We get referrals from the region, and the newborns who we had diagnosed as fetuses that come here are then cared for in the #1 NICU. We have a fabulous neonatal neurocritical care program led by Tay Chang. And our program we have weekly multidisciplinary fetal case conferences where we review all of the cases from the prior week with maternal fetal medicine specialists, geneticists, radiologists, neurologists, neonatologists. Everyone comes together to really learn how we can take the best care of these babies. We have a fetal neonatal neurology journal club, a didactic lecture schedule that covers the important topics in the field. We have research exposure in fetal and neonatal neurology. The fellows are engaged in research projects with their mentors, and they're also driving their own projects. We have fabulous research coordinator support that helps support the fellows in their research projects so that they can be both doing their clinical work and also driving some really exciting research projects. And we have excellent conferences. So Topics in Fetal Medicine, that's a monthly conference, and the International Symposium on the Fetal Brain that is done yearly. So I want to just touch on some research opportunities within fetal neurology. So some of the really exciting topics that one could look into is the developmental origins of health and disease, and I think this is a very hot area. Everyone, this consideration of maternal stress and how maternal health impacts fetal health and development and neurologic outcomes, fetal neuroimaging, ultrasound, physiologic signal analysis, so looking at heart rate variability and measures of autonomics and autoregulation, fetal biomarkers, echocardiogram, prenatal genetics, congenital infections, and placenta. Some of our research programs within the Fetal Medicine Institute, one that's very exciting to me is the SNCA, which is the Children's National and Inova Women and Children's Hospital collaboration. This is a collaboration that developed to provide us access to a high-volume delivery hospital that delivers 10,000 babies per year, and we can study the pregnant mother, labor, and babies in a large NICU. And so really kind of that longitudinal evaluation of pregnancy in the peripartum period and postnatal period we can study with this collaboration. We also have an advanced physiologic signal processing laboratory, which enables us to look at multiple different physiologic signals to study cerebral autoregulation, autonomic nervous system function, EEG in very advanced ways. There is the MRI Research of the Developing Brain Laboratory that is led by Catherine Limbropoulos, which certainly is an amazing program. We also have a congenital Zika program, and there is a fetal neonatal heart program. So these are all research areas that fellows could become engaged in. So I want to thank you for your time. So within fetal medicine, so we have our division chief is Audrey Duplessis, and I am the fellowship director. Pei Chang is also a neurologist within fetal medicine. But our additional faculty and staff under the fellowship, we have Ann Massaro and Billy Short, who are neonatologists. Mary D'Onofrio is a fetal cardiologist. Dorothy Boulis is a radiologist. Catherine Limperopoulos, who you know is the Brain MRI Research Laboratory. And Rathanaswamy Govindan is our physiologic signal analysis expert. We have two current fellows in fetal neurology. We have Ashley Luck and Sarah Schlotterer. So I want to just draw you to our website if you have more information, if you have more questions, you can go there. You can also feel free to contact me by email or our fellowship coordinator, both of us will for you there.